then push the chair back in the corner. And for the elbow, I am all the way in the corner. We're going to need all the room we have in this little room. All the way, have it against the wall. Yep. So we're going to do elbow evaluation. I'm always comparing bilaterally. I'm always checking what I think it is last so I don't miss anything. Those are big two things for me. And my goal is to try to get to some pain-free exercise to make this stuff get better, hopefully not finding anything structural. At this point, I will review the MRI a little bit more closely. You can hop up on the table. You can show him over there. Okay. So I'll highlight his name. His age is here, so I might throw that in there. And then I'm going to highlight the right elbow. And I'll jump down to findings. I will highlight what I think is relevant for the next therapist. Someone else might look at it. So slight. This is the UCL, slight sprain there maybe. The normals I kind of skip by. No loose bodies. No chondral defects. Subtle hyperintensity to growth plate. I always like to see bilateral comparisons even on radiology reports, but that wouldn't be on the MRI. That would typically be on the X-ray. And this is the summary of the impression. I don't usually highlight that. I just highlight the word impression. Otherwise, I'd be highlighting the whole section. And this is just the prescription from the doctor, which may have some useful information, but usually not much that we don't already know at this point. How'd you like Dr. Frank? Good guy? Yeah. I do too. So Evan here is 14. It says 14. Are you 15 or 14?
14.
I swear it said 15 on that report. You grew a year. You shrunk a year. They made you 15. I guess you're 14. All right. So on the MRI report, on this report here, and now that we're on objective, the default is IE for details. So if you click that, it'll just go to that observation. I see your sitting posture sucks. I'm putting that down. Sucks with an exclamation point. So, and that's relevant to any upper extremity injury. So I will put moderate forward head. Then you could use more than one thing in a column, so you can still go with slouch sitting posture, that kind of stuff, and then upper extremity posture with the shoulders might show some stuff about like rounded shoulders or how he's standing, but I'm just going to leave that. Again, if you don't click it, it's going to go away. You could always bring it back later by coming over here and searching for it if you know the right language to ask. He has no wounds, so we're not going to do that. In this particular case, because it sounds pretty orthopedic, I'm not going to spend the time on a cervical clearing, although there's nothing wrong with still doing that. Palpation I will come back to, and some of this neural stuff I probably won't do as well. So I'm going to start with basically active range of motion, which will help guide my examination. Okay. All right, so come sit around the front here. Maybe you'll be over here. All right. So we're going to just do the range of motion. Let's see, do this and that. And if anything bothers you that I ask you to do, you're going to let me know, okay? All right, so that was okay? Elbows in at your side. You can feel that a little bit? Okay, elbows down here. Palm up as far as you can go. Palm down as far as you can go. Just like this. Wrist up. Wrist down. No big deal. I'll go to the non-affected side. You can relax that. Do a little elbow strength and then some wrist strength. Hold it there. Don't let me move you. Not letting it move at all. Palm down. Don't let me move you. Don't let me move you. And I'm grading these in my head, and I'll write them all down later. Curl your wrist up. Hold it. Curl your wrist back. Hold it. Hand like that. Don't let me move you. I'm trying to go down. Don't let me move you. I'm trying to go up. Don't let me turn your palm down. And then pronation. So we got all of those. So that's your baseline. So you know normal. So if something doesn't feel right now on this side, I might not be able to perceive it, but you'll tell me. All my grades for muscle testing need to be pain-free. Okay, so we'll do biceps first again. Hold that there. Don't let me move you. Don't let me move you. Come on. Hold it there. Don't let me move you. Is that okay? Palm down. Don't let me push.
That hurts.
That hurts a little bit.
Yeah.
Palm down. Try again. Don't let me move you. Hurts a little?
Yeah.
Where?
Here.
Right in there. Okay, wrist curl. Don't let me move you. Elbow straight. I'm going to do a little extra one because we know that the wrist flexors may be involved. Don't let me move that.
That hurts a bit.
That hurt a bit more than the other one, or the same amount?
Bit more.
Bit more. Okay. And then don't let me turn you over.
That hurt.
That hurt. And then go the other way. That's fine. Like this. Don't let me go up. So you're going down. Don't let me go up. That hurt too. And then up. Don't let me go down. That's fine. That hurts a little bit. So now I'm going to go over to here. In my mind, with the elbow, the three motions that should hurt if there's a muscular strain are going to be wrist flexion, pronation, and ulnar deviation, which it did hurt. He also had some pain with triceps. He might have been co-contracting. I try very hard to not let the joint move while I'm doing this. He also had a little bit of pain with supination, which could also be some co-contraction. So I'm going to go over to the muscle testing. I'm going to jump down, and I have a touch screen, so I'm going to go to, we can measure the range of motion later, which I will do. And I'm going to elbow strength testing, so I'm going to jump over to the non-affected side, which I know is, I just use my keyboard, it's easier. Elbow flexion was probably more like a 4+. These were 5s. Whoops. 5. I'm giving you your report card. Stop slouching. It just looks bad. No, not just because it looks bad. It's actually bad for the shoulders and elbows, so be careful with that. All right, elbow extension didn't really hurt. It was just weak. Anything with pain, I try to see what their grade is without pain. Elbow flexion was actually fine. Probably more like a 4+. Actually, this one was the 4-. I mean the 4+. I made a mistake. Pronation definitely hurt, so I'm going to give him a 3+, and just mild resistance hurt. Supination, unusual to hurt, but it did a little bit. Wrist extension was fine on both the affected side and the unaffected side. Wrist flexion definitely hurt. If I wanted to add something like with the wrist, with the elbow flexed and extended, I put that asterisk, and this is a notes column over here. So I put that same asterisk, and I'm just going to write with elbow fully extended and at 90 degrees flexion. Except I can't spell, so we'll check those later. You notice they get red underlines for spell corrections. Radial deviation was fine, and ulnar deviation with significant force bothered him as well, and everything on the other side was fine and normal. So go with that. We are going to check for pain-free grip, and I almost always do it with the grip 2 position of the dynamometer with the elbow flexed. We have that actually in this room right here. Let me just do that. Just double check, make sure it's on the second notch. Zero it out. We're going to try this one. We're going to do 3 squeezes as hard as you can, and we'll take the maximum. Relax. 60. We're going to do it 2 more times. Get a good grip. Squeeze, squeeze, squeeze. Relax. That's 67. One more time. And I'm just supporting that minimally. Okay, so I'm going with the max of 67. If it hurts, stop squeezing. Go ahead. Relax. 57. Squeeze. Relax. Any pain?
Okay.
A little bit of pain, so he's compromised by pain here. So the max on the right was 57, and on the left 67. We'll clean that up, wipe that down later. Try to remind me that do that. So I'll just go over here again. And I did not expect it to be significantly less, but it is, so it's good to know. Insurance companies love numbers. So here are the special tests down here for the elbow, which we're going to do, but I'm trying to knock out everything in sitting first. So we keep goniometers in the room, and I'm going to measure the 2 ranges of motion that I think are relevant here with the elbow flexion and extension. Also, shoulder external rotation will be an important measurement for throwers because the combination of shoulder external rotation and elbow flexion extension is how far the ball gets from the body. So if he has limited external rotation, sometimes the person will drop down and hurt the elbow. So if I find that your shoulder's tight, that would be great because then we can loosen up the shoulder and then you won't feel like you have to pull your head and get your arm away. When you get your arm away, you start to strain here. Okay? And the other thing we might try to do is either today or next time watch you throw or go through a throwing motion. So arm straight out as far as you can. So he hyperextends here. And I'm going to give him, it's like 15. I'll bend it as far as you go. What town do you live in, by the way?
Weston.
So plus 15 and 150 for range of motion. That's up here, elbow active range of motion. Where is that? Right there. So that was the left, so we're going, extension is plus 15, extension was 150. And we observed the other ranges of the wrist and forearm, so I'm not worried about those to measure them. They look normal. Straighten that out as much as you can. If they have an elbow contracture, you'll often see that with, as somebody's a thrower, advanced thrower, that's 13. And then here, tissue approximation for the big guys sometimes is a reason for limiting here. 147. So these are within marginal error, so 147 and plus 13. So those are reasonable, just like that. And I could put within normal limits on these other ones if I want, because I'm not measuring these. So I'll go back later and put WNL in these, or WFL, depending on the mood I'm in for that. So again, remember, I will test external rotation again. Other objective things I'm going to do standing, always comparing bilateral, so he does it. Relax for me if you can. The bounce home test. That hurts a lot. You didn't like that one? Where'd you hurt? There.
Yeah.
So that hurt in the front soft tissue stuff more than the bounce home is typically more for the ligament or the posterior olecranon or bone spurs. So I'll put positive, but I'll also asterisk that because it's not positive for what you would normally worry about for the bounce home. So the special tests are down here somewhere, right here. So I'm going to say positive, but I'm definitely going to asterisk. Whoops. I'm definitely going to asterisk that. And it was negative over here. Drop down menu. Boom. Negative. I'll put my asterisk here again. And just write anterior brachial pain. Mild. Anterior and medial. Okay. So we got that. I do my valgus testing and everything else there lying down. The only test left to have here is going to be Tinel's. That bother you at all or shoot any pain into your arm anywhere? That does down to here somewhere. Into all your fingers or anyone? This one didn't?
This one did not.
Which fingers does that get you to? Or just in the forearm?
It mostly forearm, but like my pinky.
Just this one. So we'll say that's positive but mild, which is indicative of possibly a loose or mild UCL injury. Tinel's is down here. So go positive. It's okay to grade these mild, moderate. So I would call that mild. And then negative here. Boom. All right, now we're going to hop off the table. All the tables in the rooms are on sliders, so they're easy to move. I'll bring it out a little bit so there's room for his long legs. I'm going to have you lie down there and grab that pillow for me. I'm going to throw that under your legs once you get up here. Good. Come on up on your back. Remember, I promised we'll measure external rotation of the shoulder to help compare that left and right, too, to see if he has any deficits there. And if he did, that would be helpful in analyzing his throwing motion. So let me see how far back you can go here. And most throwers can go pretty darn far. This is his non-throwing arm, so that's pretty good motion. So I suspect he has decent enough external rotation. Okay, so he has 111 there on the right, on the left. I'll just shoot over here real quick. And I'll shoot that in shoulder external rotation. Right here, left, 111, and I'll come back to the right. And I might also check internal rotation, which I could have done standing. And we usually just have the thumb to the spinous process as a functional measurement. Pick up your head for a second. You're going to reach back there. Make sure his arms are supported. Line that up there. And then I look, and he's at 122, so that's not the problem for sure. You have more than enough there, so 122. So we might check the internal later. Okay, now to compare left and right on the valgus testing, I do these in different ways than other people do. Relax for a second. Often I'll start the other side, but for right now, to save time, a lot of people do the valgus like this at straight and then at 25 degrees, or they go here and they'll go. Does that bother you at all?
Yeah.
That bothers you, and that.
Yeah.
Yeah. So those are the ways you can do that. But I also like this position here. Move over just a little bit. This way I have an extra hand by using the table here. I get them supinated so that you can palpate the UCL at the same time. Put it straight. You don't like that?
No.
And how about that?
That hurts too.
That hurts too. And then the moving valgus.
Yeah.
He doesn't like that. And then the milking maneuver. He doesn't like that either. So he's positive for all UCL injuries or growth plate, which is both listed on the MRI as possible. Just to make sure that he's just not crybaby, we're going to check the other side and make sure that you're just not sore there in general, right? You never know. You could be doing chopping lumber or something in the backyard for Dad. All right, so we're going to get him in straight first. Fine?
Yeah.
Fine?
Yeah.
Valgus moving valgus test. And then the milking.
I'm fine.
Is fine. So those are all negative, but all definitively positive on the right. So it really leaves two differential diagnoses. Either UCL sprain. I didn't feel any gross gapping, so it would be mild, which can be very painful and uncomfortable, or growth plate separation. He's a little older for that, but indicative. But looking at him skeletal-wise, he's not done growing yet, I'm pretty sure. So we'll go back to valgus testing down here at the bottom. So we'll change all the defaults from negative to positive. So valgus at 0, valgus at 20 to 30. I didn't do varus. I did do the moving valgus, and I did do the milking test. So those are all positive. And then if I was running out of time, I could fill in the negatives on the other side later. But I'll do it since we're standing here. Whoops. Remember, the one that I did not touch, the varus test, is going to disappear when we finalize this because it's still blue and nobody put anything in there. Then there's some other special tests down there that you can add or use, and you can always add one. Again, you can go up here where the search thing is if you want to type in a test that you may know the name of or not, and you can always put stuff in any of the default boxes, like under observation or in the objective section. You could write in things right here. So for the most part, the only thing left in here that I haven't done is palpation, which it goes right here. You'll see TTP, and I suspect it'll be sore on the UCL, but also on the flexor pronator mass of the elbow, which may be like a secondary strain to helping protect the UCL. So that's where I'm going now. And I'm going to move this over to here. And again, you want to compare bilaterally on this stuff, but for time's sake, I'm going to start on this side here. And I'm going to identify my landmarks, medial epicondyle, proximal ulna, and then we know the muscle mass is right, goes into that. So I'll start away from where I think it hurts. Anything up here?
Little.
A little bit?
Yeah.
Yeah, real sore there. The muscle's been hanging on for many months trying to protect, so that's muscle soreness, because that's all that is muscle belly. Again, I haven't hit the UCL. I'm going to try to define proximal, middle, and inferior. On this side, I don't like to reach across, but I just want to make sure this feels all fine.
Yeah.
Yeah, and this is a little sore or no?
No.
Okay, so we already know that. We can go back to that. All right, so now I'm going to move into, that hurt a lot.
Yeah.
That's the proximal ulna.
Yeah.
That hurt even more, and that's a little less. So I'm going to call these moderate. I mean, if it was severe, just even that would hurt, but that really doesn't. But once I get down there a little bit, you get it, yeah. There and there. And you threw yesterday.
Yeah.
So we have to consider that as well. But that's not too bad, but that's still sore.
Yeah.
But definitely down in here and down. You hate that.
Yeah.
Okay, and it's not like a tear of the strain of the muscle as much as it is what's underneath here more. When was the MRI done?
It was
Not
Friday.
Exactly. How long ago?
Friday.
Oh, just
Friday.
not even a week ago.
Yeah.
Okay. So I'm going to go over to TTP over here, which is tenderness to palpation. I'm going to list the different things. So I'm going to do flexor, pronator, muscle, and I'm going to just go right there. I'm going to go right. Actually, I'm going to go right here for all of these are going to be right. I'm going to put colon. It's just my way of doing it since I know in my head they're all sore. So I'm going to put moderate, and I'm going to put UCL, distal, and mid substance, moderate. And I'm going to do proximal, mild, and then I'm going to go semicolon. I'm going to put left side all nil. So there's no tenderness on the left side. Skin temperature is normal. We also are using the infrared things now to actually get a temperature differential on things instead of just using our hands. There's no visible edema, so I'm not gonna put that down. And you wouldn't suspect there to be anything significant for that. So we're pretty much done except for internal rotation, but there's no reason to believe that that would be an issue since he has such good external rotation of the shoulders. Just for sake of time, and it's good for you to see this. If you think you might want to test something later and you want to bookmark it so you don't have to add it back later, just put not tested or TBT to be tested, and that way you know that you can always put it in there later if you want. Remember that most of this information is for you later versus the insurance or the doctor, because it's really more important that you and the other therapists read and understand what's going on. So that's it for the objective section, except for the functional questionnaire, which for the elbow we use the dash, for the shoulder we use the pen score, and then the other body parts we use different things. So that's it for the objective, other than if it was his shoulder, I probably would have his shirt off and have watched his scapular move and those kind of things.